This program is brought to you by Ignite TV. Now you're in command. Visit Rogers.com for more details.
Special on the opioid toxicity crisis here in Grey Bruce. I'm David Shearman. My guests today are Dr. Ian Arra, who is the Medical Officer of Health for Grey Bruce, Dr. Zayed, who is the Grey Bruce Public Health Physician Consultant and Lead Epidemiologist for Grey Bruce, and Mr. Alan Barfoot, who is a member, or actually the chair, of the Grey Bruce Board of Health, which is the governing body for our Board of Health. So I want to welcome the three of you to talk about it's a serious issue, a very serious issue in our community, and that's the opioid toxicity crisis. Now, the crisis has made a lot of headlines in both locally and provincially for quite a long time. And mostly locally, because Grey Bruce Public Health has reported clusters of drug poisonings in the past few months, and most recently there were something like 14 overdoses and 1 fatality. Are things getting better? Are they getting worse? And what's going on? Dr. Arra.
Well, thank you for having us, David. Always great to be on your show. As you rightly identified, it's a concerning health issue and public health issue. In terms of data, the situation is getting better. Not to say that we need to give concern and more concern, because any single preventable death is one too many. You look at the data from 2021, the number of deaths was around 40. Related to opioid. In 22 was about half that number.
Is this for Grey Bruce?
For Grey Bruce.
For Grey Bruce, okay.
For Grey Bruce. So that's the main outcome you look at, and it was reduced by or declined by 50%. You look at the number of overdose, comparing the 3 months we just went through in 2023, comparing to the 3 months from the year before, 2022. It's actually 12 overdose at this point. Around the same time it was 14. So the number didn't change, and this is the main concern for me. The number should decline, and decline significantly. When you're looking at numbers that are less than 20, the sample size that usually statistics looks at, it's very difficult to infer rates or conclusions from small numbers. So 12 and 14 is, although it's 2 less, it's not much less. But in the bigger picture, we have an array of interventions, and we're looking at everything, nothing off the table. And even the things that might not be looked at, we're looking at how to implement it and evaluate it in pilots if the need be. So all in all, there are a number of people who are getting overdose. There are unfortunately a number of people who are losing their life, and that's not easy on the families, on the community. In smaller community like our communities, any death is very significant. You look at the general picture, we need to tailor more concern. And to go back to the core of your question, there has been a number of overdose, and it has been in the media, and mainly the fact that we are looking at it and we're putting it under the microscope, similar to last year, similar to the year before, but with more resources, more intention to it, that might make it bigger than it is. But again, like it's a very fine line. Any single overdose is a big thing, and the death, obviously, it is. I'm not sure if Dr. Zayed or the chair would like to chime in too.
Oh, sure. Dr. Zayed, what's your take on where we are in Grey Bruce right now in terms of opioid overdoses and the toxicity crisis?
Thank you for having me in this show. For Grey Bruce, again, as Dr. Arra mentioned, we have more data right now. The alert system is working, and we are integrating many services together. There is for sure a COVID effect that has affected the social determinants of health and reflected on the opioid use and illicit drug use, and also the illicit drug use landscape, where there are more users and the users who do not know what they have, and in the same time the drug itself. So it's not something that is only in Grey Bruce, it's all over Canada and all over the province. The thing that now we have adulterated drugs in the market or in the streets, and this is an issue that we need to address. And in terms of number, we have more knowledge about the numbers. It needs to reduce, but we need to know what all the components that we are dealing with.
Sure. And what about the role of government in this? Medical officers of health and the public health unit are public health. What's the role of governments in all of this, Al?
I think, well, again, thanks very much for the invite to be here, David. I think, the answer to your question, I think the board runs that fine line on governance versus operational. And, from a board perspective, I mean, we certainly support our experts. Here are two experts at the table here. We don't get involved in the operational part whatsoever on any of the issues, and we just support them for whatever they need to be able to do their jobs moving forward. From a municipal standpoint, I mean, I can't speak to that now since I'm not an elected official, but around the table, the discussions that we have with the board members. I mean, obviously
because they are municipal politicians.
They are.
So they obviously have some input into the
So
decisions.
they bring their concerns forward, and we deal with them at the board level on the best way that we can from staff standpoint.
Sure. One of the things that, and we'll get into this a little later, is that there are some innovative programs that are happening, and we'll talk about that a little later. But they are supported by the county and by municipalities. But let's not get ahead of ourselves. Dr. Zayed, you alluded to the fact that we have an issue with an adulterated drug provision. Illegal drugs are adulterated. How exactly are they adulterated? We know the big word is fentanyl, but there are other things that get mixed into illegal drugs. What are you seeing locally?
So since 2018, this has been a big issue all over Canada. And recently in Grey Bruce, there has been more drugs that have been adulterated or contaminated, so to say, with other more potent drugs like methamphetamine and benzodiazepines. And recently there has been an alert from the Chief Coroner Office of Ontario about another drug that has been around the U.S. In the last couple of years, called xylazine, and this drug is not used for human, and it's actually a horse tranquilizers, but they kind of taking a more sedative effect or more potent effect. So they adulterate this fentanyl or opioid with this kind of drugs. When we see benzodiazepines are depressant, but their effect can be more potent in terms of sedation, affecting the respiratory centers. It also can lead to more dependence. So this is more usage. So more usage and have higher doses of consumption. And of course, the end result will be that we will need more, these people will need resuscitation and taking naloxone. And even naloxone in some, they will need more naloxone doses because the usual effect of naloxone acting as an antagonist to fentanyl and opioid will not be sufficient. So they will need immediate resuscitation, more naloxone, and of course their usage pattern is changed here in terms of frequent users, frequent using of the drug, especially that they have more potent drugs, and this leads to dependence, which is frequent using.
It's kind of a vicious circle, isn't it?
Yes,
yeah.
Absolutely.
I want to come back for a moment to the animal tranquilizer contamination, which I have read quite a bit about recently in the States as well. It can't be recovered through the use of naloxone, I understand. So if you are using a drug, your illegal drugs are contaminated or with xylazine, I think it is?
Xylazine, yes.
Xylazine. Naloxone is no good because it doesn't work. It's the best way to look at it. So if you're thinking naloxone is your crutch or your safe place, not going to work if the drug is contaminated. But we'll also talk about naloxone a little later in the show because that's quite an interesting direction to take. I want to go back to something that you referred to, Dr. Zayed, and that is the impact of COVID. And what have you seen change since COVID hit and now that we're moving out of the intense phase of COVID? What changes are you seeing from before, in the middle, and afterwards?
That's a great question, David. In terms of COVID, there has been, of course, people have been like sick and need isolation. But in Grey Bruce, we really worked very well regarding the social determinants of health. So we were trying to overcome any reduction of access to services, like these people, for example, people who use drugs, if they are added to that COVID infection and isolation. So we try to form a team working on the ground, composed of harm reduction team, Grey Bruce Health Service, CMHA workers, and pharmacies. So coordinated team in the community to address this issue of isolation. So we were trying to deliver the access of service, but again, this is not. This is complex and added service that we need to be aware of. In addition to that, the COVID effect affecting social determinants of health in terms of income, small businesses, employment. So this opioid crisis is very intimately related to social determinants of health. The stress, the mental illness. So all these have been aggravated. And during a big outbreak in one of rooming in areas where there are mostly people who use drugs, and working together as a team in the community, we came up with the supportive outreach service, which is the SOS. That's why you can see a difference between 2020 and 2021 in terms of the number of deaths that have been decreased by 50%, and in the same time the number, for 2022. So we started this team in October 2021 after this outbreak. So the number of deaths in 2021 were 40. So it's decreased to half of that, around 20. Mm-hmm. The number of ED visits, emergency department visit, was reduced because this team was reaching out to people and trying to mitigate the effect of the social determinants of health related to access of service, and even trying to link them to employment or having a health card. So many services are working together for that. So it's not only the health service, but non-health service as well.
You mentioned the SOS service. That actually was one of the questions I was going to raise, because I think that's been one of the success stories from anything I have heard, where you've got the representatives of local governments, because I know here in Owen Sound it's at the farmers market every 2 weeks, and it's in Hanover, is it not, as well?
Yeah, there is two fixed sites, alternating on Wednesdays from 1 to 3. One in the farmers market and one in Hanover Center. But it is one of the service. The other service is really the very successful service of mobile team, which are everywhere and acting every day. But this service really needs a lot of support and funding and continuation, because it's really very successful.
Yeah, so I was talking, one of the interviews I've done for Rogers was with the head of the paramedic service in Grey County. And they are one of the key components of this, because they are right there in the community meeting with people. But it's not just paramedics. There's, as you said, Canadian Mental Health, the United Way is there. Y Housing Services are all in this place.
Health Service.
And the cool part, I think, is no one is being compelled. They're being invited in. And that's the difference, because it may take 2 or 3 invitations, or 4 or 5 or 6 or 10, but people respond to the invitation to increase services or to get a health card, to use your example. But that's been a real success story, I believe. Am I right, Dr. Arra? Is the SOS program been a success story from your perspective?
Indeed, yes, absolutely, and the data speaks for it. If I can take a stab on the last 2 questions, then I'll branch a bit. I echo everything Dr. Zayed said. The effect of the pandemic on the opioid crisis. I learned a long time ago there are simple answers for complex issues that wouldn't probably suffice. There are many angles to it. Obviously, it was a stressful time for everybody, and stress is a negative factor on many fronts, but it's very important to stand by the data and look at it. You look at, for example, in 2021, I believe, the federal report came out from Saskatchewan about suicide. Mm-hmm. Suicide rate did not change a bit in 2020 and 2021, the early 21 when the report came out. It's a complex situation where a person would arrive to that conclusion or that eventually that situation that's not easy for themselves or their family, but it might not be intuitive what happens. There are many factors comes into it. Obviously, the pandemic was not supportive for people who are in isolation and might be using alone, and they had a chance for survival if there was somebody around them. But at the same time, you look at the other side, the work that we've done, and the bigger team, the Grey Bruce team, not just the health unit team. We developed relationships, we developed approaches. One of them is the SOS. In my opinion, it was a game changer for the management of that specific outbreak, but at the same time, it's a gateway to show what public health does. I recall a mentor, and this is something known in public health, you might have heard it before. Public health earns its credit in health protection and invests it in health promotion. So the health protection for one example is the pandemic. You protect health through prevention of transmission of disease. Then you have enough leverage to do more work in tobacco cessation or opiate or preventing many issues related to health promotion. So you'd look at the pandemic, it was a perfect opportunity to put public health in the center, and for it to do what it really does very well. If I can go on a little tangent, I promise you 1 minute I'll come back.
And I'll bring you back, Dr. Arra, trust me.
Ottawa Charter, if you Google it, you would find a nice graph about different approaches for health promotion, and health promotion is is what is the essence of the solution for the opioid crisis.
It's the other side. If you think of it as a coin, on one hand, you've got health protection, and the other side, you've got health promotion.
Correct.
Yeah.
So the Arra Charter would look at public health work, and it applies almost in every field we look at. We have three main roles: advocate, mediate, and
Enable.
Enable, thank you. So you put this in the center, and you look at different approaches in public health. Some of them is building public policy, healthy public policy. This will actually affect all the other factors that I'm going to mention. Create supportive environment. In the opioid crisis, the supportive environment can be building playgrounds and sports for teenagers, as complex as that, or as simple as a sticker on a subway. If you need help, call this number. You look at the developing personal skills, the individuals that are dealing with issues related to substance use. There is definitely the work that can be done to support in that endeavor, and there is the community action, strengthening community action, and those are four components. And one of them, the fifth one, is reorienting the healthcare system. So public health is not healthcare. We're not the hospital. We're not the primary care, but we support to reorient. And our role, as I mentioned, mediate, advocate, and enable. So
Enable. It's very important.
the SOS, back to the final question you mentioned, SOS is an example where many services came together. Enforcement services, police and MPP and local police have been essential in that work. Pharmacies, many sectors can come into play to support that SOS. And this is where public health can shine, especially if we have the leverage that we had from the pandemic. I don't know if I put it all together.
No, you actually have, because in speaking of the police, I recall hearing a story of someone who told me this because they were directly involved. A police officer was used to enforcement, and they got involved in some of the work with marginalized populations, and all of a sudden they say, aha, they're not breaking the law, the issues are bigger, and here's what I can do in this situation. And to see the police, instead of going out and arresting people, doing things that are helping to build trust in the community, is that kind of work. Same with the paramedics, same with the other agencies, who all have these connections, but now they're coming together, I suspect. I want to move on a little bit, if I can, and ask you a little bit more as physicians, because let's face it, you've got to be a physician to be in your position. Who is at risk in developing substance abuse issues, or I think it's called a substance abuse disorder? What are the factors that put people at risk for a substance abuse disorder?
Take a first step at it.
Okay, so, Dr. Zayed.
Okay,
Dr. Arra.
I was going to take. Yeah,
Okay,
I was going to take first step at it. The answer is going to be depends. If you're dealing with a highly addictive substance, many people might not stand a chance for 2 or 3 doses to be dependent. Other substances might be less. There is individual variability in it, definitely. There is the frequency of use. There are many factors in this, but where it has the heaviest burden, depending on looking at the social determinant of health. People who are disadvantaged, who might not have the resources, would suffer dearly through this process, and obviously a solution would entail looking at all these factors. I'm not sure if you want to build on that.
I just want to look at it from adding to Dr. Arra's his explanation, to look at it from a socio-ecological model, which involve individuals, families. So it's really a story: individual, families, community, system, and society. So it's all involved and it's all really connected. So if an individual had coping skills that are vulnerable due to many issues like adverse childhood experience violence in around the family environment, experiencing family member who has been incarcerated, experiencing isolation, stigma, same as for families who have low income, some vulnerability issues, violence, and then if we go to more like society system, so school system, we need to have lack of resilience, lack of coping skills, education system, health system, all this system working together can affect individuals, can affect families. And then if we go to a community, if there are more stigma or marginalization, no cohesion, no social networking. So all these factors, they can be risk factors, but in the same time, if we are aware about them, they can be protective factors on the other side. And we have these pillars of working with opioid. That's why we find it it's a complex problem. It's not related to just delivery of service or treating someone. It's more complex than this. So when we have pillars of working with that, it works with enforcement, treatment, before treatment, even prevention, working on this primary prevention, and then we have the treatment, and we have the harm reduction, meeting people where they are, and working with Ottawa Charter in the same way that Dr. Arra mentioned, through this kind of components can be helpful and can help, can support, and we can have these tools in when, for example, when I talk about reorienting the health service, if we don't have access, the people who use drugs do not have access through emergency department or long waiting times. So how we can modulate the service around how that they can access this service through outreach or through phone calls or through a different support system.
Yeah, so like you say, it's a complex picture, but at the same time, it's not a hopeless picture.
No, never hopeless.
Never hopeless.
Never.
Because some people will say, oh, goodness, but at the same time, what I'm hearing you say is there are opportunities for
Always.
The community and for citizens to work with this. I want to come back to one other question about about risk factors. Are there additional risk factors for people who overdose? So we're talking about that portion of the population who use drugs and use, in particular, opioids. What puts them at a special risk these days?
Again, lack of awareness and lack of knowledge about what they are using, and maybe the overusing. So they are not aware about the drugs that they are using, and they are not connected enough to the services or the support system. I can tell a story again. SOS is our, it's our baby, really. So the people who have been connected to SOS, no one of them had overdose. So that's by numbers. They haven't had any overdose, and that's really a success. 1/3 of them have been treated. So although that we meet people where they are, we don't really judge. But there are people who really choose not to take drugs after certain time.
Right.
It depends. Everyone has his own journey and his own story. But I think one of the things that we need always to be aware and alert and vigilant. One of the things that happened after this cluster, that we had a situation analysis, assessment of what is happening at this period. So we find that these people have not been connected, and they have been, like most of them, 90% of them had naloxone. But after the naloxone, so what is after the event? What is the post-event? We need to connect them to service. So we worked on certain strategies to try to connect them to the outreach service in the community, and working with paramedics who are really great supporters in Gray and Bruce, working with the police so that we can get some sort of more details about people who have experienced overdose and try to connect with them. Some may not want, but if they are connected after a certain time, I think that would be helpful for this awareness. Another thing that we are working on right now, and I think we are lacking that, but it would be very helpful, is drug checking. So drug checking service is something that...
Can you say more about drug checking services? That's kind of, people could bring their drugs in and they can have them checked. Is that what it is? Or there will have to be a kit that they can get to check their drugs to make sure they are what they are?
There are some fentanyl strips that can be available, but I'm talking about something more like evidence-based drug checking. There are in Toronto 5 sites for drug checking where there is kind of a spectrometer or an equipment to check the remnant of drugs after exposure, overdose, or check some of the used equipment and see if it can give us some percentage and quantity of the content of these drugs. Is it fentanyl, non-fentanyl, or benzodiazepine, and it gives it with a percentage. So we will have as a health team or community working awareness, and we provide this information to the users so that they are aware. There are more evidence-based that this will help them to avoid risk behavior, and some of them would like more to connect with service after they have been not wanting that.
It's interesting you say that, because one of the myths out there is that possession for personal use may be criminal. I mean, the criminal code is still in place, but if I understand from Chief Ambrose, that at this point they're not going to charge you if you have a small amount for personal use, and if you want to get it checked, it can be done.
Yes, with Good Samaritan law,
Yeah.
like if someone else have this drugs, they are not charged by law. In the same time, if someone is using for like have some possession for use, they are not charged.
Right.
Yeah.
At the same time, possession for trafficking is absolutely chargeable.
Absolutely.
That's what I recall Chief Ambrose saying. So
Yeah.
it's kind of like an
different.
apples and oranges, and it's a little bit of a different way of looking at things than we've been used to.
David, can I
Yes,
just-
sure. Yay.
No, I just...
By all means.
Well, I hope from your listener's perspective.
Yes.
I mean, normally you talk about the health unit and you think of the Healthy Babies program.
Yes.
You think of vaccination program with the schools, and that, but the general public doesn't see the detail that these people go through on a day-to-day basis, and all this that's come forward. They don't realize the stress that is on them and the work that it takes to do that. So from a board perspective, and I think as Dr. Arra had pointed out and Dr. Zayed had pointed out, the health promotion is something that is driven basically at every meeting as far as how we can help them moving forward. But I think your listeners just need to realize just how stressful this is on these people, these moving parts moving forward. And as the discussion has gone here about all the other organizations that have been involved.
And I think part of that too, Al, you make a very, very good point. And yes, I'll be trite for a moment. I don't understand how Dr. Arra and Dr. Zayed, you have no gray hair. I don't see any gray hair. So, and you don't have any stress lines. So
Trust me.
But I think that your point is well made, that actually, if I can go back as far as Walkerton, the Walkerton water crisis, it is our public health units that have this huge responsibility of not just water, but a whole bunch of other things, and opioids. So I think it's called population health, is the big overarching term, that's on your shoulders. So it's a big weight.
Indeed, guilty as charged. Yeah, the population health, that was one of the names that were debated for the specialty public health preventive medicine, but my understanding at the provincial level in a couple of provinces, they already used that term, so it couldn't be used for our specialties, but that's exactly it. And with the responsibility comes the authority. The Board of Health has absolute authorities during certain situations. One of them is the pandemic, and I do believe the main principle we used in deploying any intervention was the least intrusive. Anything that comes across with education for a solution, we don't need to go to a warning, we don't need to go to an order. You look across the province, there are many orders that were issued, letters of instructions to businesses. In Grey Bruce, we did the very, very minimal. There was one order for mask use that is temporary until the province issued their order, and there was, I believe, the other one for isolation that was applied for specific individuals who really challenged the narrative. But again, the responsibility is definitely there.
Yeah. And when we think of opioids, we have to remember that this isn't your point is well taken about education. This is an educational opportunity, and it's an invitational opportunity. No one's being strong-armed. Like I said, I've been told that the SOS program, people will be offered an invitation 5-10 times before they say, yes, I need this kind of help. So it's invitational. It's not strong arm, it's not coercive, it's invitational, and that's a huge difference. And I think the results speak for themselves. And yes, but I think the other thing to remember too is that, Al, the members of the Board of Health, who are municipal politicians and provincial appointees like yourself, also bear that responsibility. And I'm sure the concerns that you hear around the table at the Board of Health are just as important about the opioid crisis as other public health issues.
Yeah, and I think we all see it out and about shopping. There's the social impact of it. Now, it's been mentioned many times about how short everyone's fuses are now. You see people going into a store, and if something doesn't go right off the bat, I mean, they're jumping all over an employee, and it's like, give them a break. I mean, as I say, I think we've just developed, and we need to a point where we're being too stressful to as society. We need to take a step back and say, look, we're all humans, and we all need to, have a little bit of slack here moving forward, so that we can all get through this.
And I think that we have underestimated the impact of COVID.
Oh, exactly.
And while we're talking about the opioid crisis, just as kind of an aside, I did hear from down in Toronto, the student trustees of the Board of Education said, if you want to understand the violence we're experiencing in schools, and we're experiencing it here in Grey Bruce, the fact that we've had 2 years out of school, 2 or 3 years out of school, and not had our socialization, this is what is playing out in our school system. And when I spoke to our board staff here, board leadership, they agreed. So this impact of COVID is is huge. And I hate to say it, but neither of you are going to be having to worry about a job for a long time. I mean, your work.
Well,
Because I don't think you're going to, I mean, the need for public health will still be there, is my point, always.
Point taken, yes. The thing is, in practicality, many MOHs either retired early, changed position.
Yes.
Even the recruitment for specialists in public health has plummeted.
Really?
Yes. So, you do the job because this is what you signed up for. This is your ethical duties, your professional duty, and yes, absolutely, there is a lot of work in public health, but it is not easy. Back to your point and the responsibility of it. And if I can tie this into what the chair mentioned, the people are easily agitated these days, and you look at the opioid crisis itself. You're dealing with people who already lost many things. Yes. And usually, even without a pandemic, the approach is to be the least intrusive, most inviting. I mentioned orders that would be for outbreaks or infectious disease, not for opioid, like you mentioned. It's always invitation, and even the system is maturing, the legal system and the enforcement services. They're realizing this is not an option for a person when they're hooked up to these strong medication. We have to go with the least way to invite them, the least intrusive way to invite them.
Right. And I'm thinking of some of the other programs. I remember getting a tour at Public Health of the needle exchange program, because that's been a key foundation piece for many years of working with people with addictions. That's still in place, isn't it? The needle exchange program is still in place. And I remember being astonished at the number of exchanges. Do you have that number right off the top of your head of how many needles were exchanged last year? I know a few years ago it was about 30,000 in 1 year.
30, I believe it's way more than that.
Okay.
I remember before the pandemic, the number was around 190,000, 200,000. So obviously during the pandemic, many programs were affected, but at the same time, this is one of the programs that is built in and operational. Like it doesn't require the active staffing, rather just the opportunity for people to attend certain sites.
Right.
I don't know the exact number.
That's a lot more than it used to be.
Yes, I believe so.
Well, it works. But let me riff off that a little bit, because one of the other questions that often is asked is, well, what about safe consumption sites? Is that going to play a role here in Grey Bruce, do you think, either now or down the road? Do you foresee that?
Safe injection services might work, and again, there are many interventions, David, in public health. You need to look at what's the need of the population. For a safe site, specific site to operate, you need a number of staff to be present, but more importantly, the need of the community. In Alberta, when the first site was put together, was in a space of 4 blocks. There are a few thousand people who are using substance. So in big cities, probably that's an intervention that's very helpful. In Grey Bruce, with a wide geography, if you put it in one center, might not be enough users to actually operate it. Rather, the services remotely, or if we look at different interventions, and Dr. Zayed is actually actively looking at this for the past few weeks, more than weeks, but to see how we can design a solution that would work across Grey Bruce. Because you put a center in Owen Sound or Hanover, what about the rest of Grey Bruce? And is there going to be enough users for it to justify having 2 staff? And it's worth mentioning, this is all clinical care health system. This is not under Public Health Authority. We support them with building a case or looking at the data and evaluate the program. But I believe Dr. Zayed can way elaborate more on the solutions that are available.
So again, when we talk about safe consumption sites, what we really need from that at a local context. So we need to know exactly the need, the appropriateness, the feasibility, the equity, the accessibility, the acceptability. So all these factors, we are studying it and see our local context, how we serve people better in Grey Bruce. So when I talk about Grey Bruce, it's different than talking about Toronto or talking about Ottawa, so it's different. So what is our context and how we serve better? When we plan for SOS, it took us a lot of work to plan for service, to put an evaluation framework and put indicators for success. So again, this is a great idea, but how we put it in a way that to be successful, which is the most important. Maybe we are looking at different scenarios right now. Is it going to be like supervised consumption service by phone, maybe, or something related to the SOS team, mobile unit that are serving wide geography. So it is in our planning, but we discussed through the steering committee for drugs and addiction and alcohol, and we discussed it with the alcohol strategy leadership and to see the best option for that.
Sure.
I think that plays back into then the whole educational program as to what is that the best way to do it and how to do it.
Let's come back to something we touched on earlier, and that's naloxone. And some people think it's a magic cure-all. It's not. And one of the things that has perhaps been, I remember going to a pharmacy and getting some prescriptions, but the person in front of me asked for 2 naloxone kits. And I'm thinking, okay, that's different. I've been to lots of pharmacies over the years, but never seen someone ask for naloxone. But fine, yeah, and they were, no problem. What naloxone is, what does naloxone do? First of all, Dr. Arra, what does naloxone do?
So naloxone works specifically on opiates. Doesn't work on many other medication, whether it's not heroin, cocaine, or benzodiazepines. It has no effect there. So it's very limited to working on opiates. And what it does, it hooks up to the receptors on the cells that are affected by opiates and prevents the opiate from doing its work. It actually takes away the high, reverses the sedation aspect of it, and it's worth probably pointing out people who administer naloxone or the people who are trained how to administer it need to be aware of what would happen after. The person might be agitated.
Yes.
And it's not, you inject it and that's the end of that. Calling an ambulance is warranted. You would hear sometimes about the stats, or you look at the stats and there were overdose. Naloxone was administered and the ambulance was not called. And again, that's a risky situation. You look at the data itself, based on what you said and your experience in the pharmacy, there is a story there in the data where you would see the number of calls to the ambulance increasing, but the number of visits to the ER decreasing. And you look at different ways to explain it, but probably the most likely reason or reasons is less stigma about drugs. So people are actually using naloxone. People are calling the ambulance. And again, this is part of the good story, and sometimes I try to shy away from pointing these out because I don't want people to take their foot off the gas. This is still a concerning crisis. Yes, again, we have many interventions, many partners doing many things around the table, and we have been the victim of our own success in public health, because if we do it right, you don't see it as much. We try to compensate by putting the media lens on it to actually let people know that if we can reduce this number to 0, that would be a success. Anything other than 0, I wouldn't sleep well that night.
But I think that the point is well taken. That in fact, if I recall the naloxone instructions, it's rub the chest, get people rolling around a bit, so that they're agitated or they're awake, and if that, then call 911 and then administer the naloxone, just so that it's not a cure-all. It is a step, but to call 911 is first. Get the paramedics there so that they can be, and because, of course, in Grey Bruce, sometimes our response times can be longer than we would expect. So it's important. So I think it's very important that you mentioned that naloxone may have actually prevented hospital admissions or at least trips to the ER, because it's all of a sudden, it's part of a much larger picture that seems to work. It's part of a larger picture.
That's a safe statement, and I would echo what you said about the importance of calling 911, because it could be opioid, could be something else, so naloxone might not work. It could be totally different situation. I believe Dr. Zayed wanted to add something about naloxone, I noticed.
So naloxone is a life-saving measure for sure, and we still want people to use it, to be trained to use it, and not to consume alone, so that in case they have experienced overdose, someone else can be helping them to save lives. But again, the situation is complex, given that we have adulterated drugs right now. So people, in addition to the awareness about naloxone and the social responsibility and the reduction of stigma about it, it's important also as a role to know what they are consuming, and that this can be affecting their response or life as well.
I was going to say that we think that. Well, let me step back a minute. One of the things I did hear from the messaging from public health is never to use alone.
Yeah.
And I'm thinking of sometimes of the demographic that may be watching this program, and it could be they may have children or grandchildren who may be using opioids. Not that they approve or anything, but it just life is. It's always good to have that kit handy. Doesn't matter who it is. Could be your neighbor. It could be, someone in the park. You go for a walk in the park, and a naloxone kit could save a life. So that the idea that it's just for people who use drugs. No, it's not. It's for all of us.
Absolutely,
all of us.
I agree, David.
Now, one of the interesting things that I asked, and I'll ask you because you probably will know. Does cold affect the potency of naloxone? Like if you keep it in your glove compartment in your car in the winter. I recall seeing something about Calgary Public Health said it had no effect. It's still usable.
Yes.
Is that true?
Yeah.
So you can, the cold will not affect the naloxone.
Yeah. It has an expiry date.
Yes.
That's the most important thing to notice. And it can be changed and from public health or other places where naloxone is
a pharmacy, for example.
A pharmacy, and our harm reduction team really worked hard to expand the distribution and the training. It has been even tripled from last year, the number of sites and the number of training sessions. And it is really easy and available. Like I can say it's available, but most important that people need to check the expiry date. Other than that, there is nothing really as a barrier to consumption.
That's good. That's good. That's good to hear, because it's one of those things that the more available we are, the better we all are. The more education we have, absolutely, absolutely, Al, absolutely. Now, I understand you're working on a project which is going to improve early surveillance of in the overdose crisis. Can you tell us a bit about that, Dr. Zayed?
So there is a first project that we worked on is a locally driven project funded by Public Health Ontario. Is mainly focused on prevention. For youth between 15 and 24. The recent project that we are working on and co-leading now with Kingston Health Unit is about, and we are in the stage of preparation of that project, is related to early surveillance. So it's related to how we, for example, I have a situation right now in Grey Bruce, but when I go through the media, I find similar situation, for example, from January. So how I have this information handy at the time, so that it's all there in a repository or a portal that is helping everyone, so that these things happen like we have it at the tip of our fingers at any time. So that's about early or enhancing the early surveillance and knowing what the changing market are, either through media, through gray literature, through data. So it's really a very supportive tool that we think it will be very helpful to get ahead of this crisis.
So it's a form of monitoring of the news media, of public reports, whatever you can get your hands.
Wherever it is. Like
wherever it is.
There was something, I think, in Google before about the flu watch. So it is similar to that situation.
So by using public media, you'll get a better handle on the situation on the ground, because it's
a more real time.
Right. Yes.
Information.
Yeah. And it's really interesting that is so critical, because we kind of think of, oh, well, you guys know all this stuff. Well, no, you don't. You got to find the data. And where does the data come from? All kinds of sources.
All kinds of sources. So we really need to have a good grasp on all information, because it's not about only drug. It's a market. It's really like stocks. You need to be on the pulse of things.
Right.
And that's where, from the municipal standpoint, from the board members, they're more in touch with the community as to what's going on with that. So we look forward to her monthly updates,
sure.
where things are going that way. So.
Yes, because as a retired politician, you know that you're going to get phone calls if there are certain issues.
Yep.
And it's funny you should say that, because I've discovered that anecdotal information. Well, let me give you a real example. During hunting season last year, orange toques were handed out to prevent people who were in the woods, living unhoused, from being at the risk of being shot. Not that a hunter would do it purposely, but accidentally. And what I heard when I handed out some of those toques in the southern part of the county was, well, I've got some people living in my bush, or I know that, I'm anecdotal information that may or may not be known to the police, but it's anecdotal information. It's absolutely fascinating how effective it can be.
It is, yeah.
I want to thank the three of you for being a part of this conversation. The opioid crisis is absolutely top of the headlines. It affects everyone's lives here in Grey Bruce. But Dr. Zayed, Dr. Arra, Al Barfoot, a pleasure to have the three of you here and try and get some facts out there. So deeply appreciative. And friends, thank you for joining us today. We hope this program has been informative for you. And I would say, if you have questions, call the Board of Health. Is that fair?
Call the health unit.
Call the health unit. Not the Board of Health. Call the health unit. Thank you for being with us, and thank you. We will talk again.
Call the Rogers TV viewer response line, email us, or connect with us on social media.
all journalism students. Omni Television is once again awarding scholarships to qualified students pursuing a career in third language journalism.
The Omni Scholarship has